Good evening. Welcome to the show tonight. I've been having a sneezing and coughing all day long. And, I looked it up and it's symptoms consistent with what they call a upper respiratory tract infection, URI. So thankfully, the topic tonight is on that very same subject. So, I'm going to learn a lot about this topic, and I hope that you get your pen and pencil ready because you and I are going to learn about what they call URI. So stay tuned. We have a great show for you tonight. And as usual, it's Monday and it's fresh, natural, and live. Hello, it's amazing. I feel so much more relief now. I don't know. It must be the fact that our experts are in the room and I'm about to hear about this knowledge about URI. It just seems like, that little transition phase is all I need, getting closer to the knowledge. And what we hope to share with you tonight, as we do every Monday night, is share some knowledge to empower you on ways to optimize your health. This is the time of year that upper respiratory tract infections are very common. Of course, everybody's talking about the C disease, but it's really not the only cause of upper respiratory tract infections. There are many causes of upper respiratory tract infections. In fact, oftentimes the symptoms of upper respiratory tract infection could be due to an infection, or it could be due to things like allergies or something else. And so I have my expert panel here tonight that's going to help us decipher this whole clinical syndrome of upper respiratory tract infection. And of course, we're going to try to empower you with information and knowledge on how you can prevent such a thing, but if not prevent it, which is, I think, is most important, at the very least, we're going to try to help you suppress symptoms and get relief as soon as possible if you are unfortunate enough to contract an upper respiratory tract infection. So without further ado, I'm going to bring my friends and colleagues on. We have Dr. Floyd Atkins, who will be with us tonight. Dr. Atkins, how are you doing?
I am doing wonderful this evening. How about you?
Just fine, just fine. Thank you very much. And we have Dr. Pamela Atkins, your partner in crime. Hello, Dr. Pam Atkins. How are you today?
Hi, good evening. I'm doing well. Good to see you all. Good to be here.
And last but not least, our presenter tonight, Dr. Celeste Palmer. Dr. Palmer, hello. How are you today?
Hello, I'm well.
Welcome to the show. Welcome to the show.
Thank you.
So, this whole issue of upper respiratory tract infection is one that, it's a common clinical syndrome. It happens to people year round, but this is the season that we see more of it. And I know you see it a lot in the pediatric population. Kind of help us out with some, what is upper respiratory tract? Before we get into your presentation, kind of give us some introductory comments in terms of your experience with upper respiratory tract infections and how it impacts your practice and your patient population.
I mean, and we'll talk about this too, but it is the number one infection that we see most of the time is going to be some type of upper respiratory tract infection. So it keeps us very busy. And of course, this time of the year, it keeps people very anxious. And so that's why I wanted to talk about upper respiratory tract infections, not just for the kids, but also for adults, because it affects all of us. And to just get some history behind it, because sometimes if we demystify illnesses or other things, it helps it not to be as scary, because I feel like people think that these viruses kind of come out of nowhere and attack us. And it doesn't necessarily work like that. So just want to give some information behind it and what's happening inside of our bodies.
Wonderful. So anyway, so let's get understanding upper respiratory tract infection. What's our foundation? Another URI. And so, we start sneezing and so on and so forth. So what should we make of that? Help us out with some of the background information.
All right. So want me to go ahead and get started?
Sure. That'd be fine.
So I said, oh my, not another URI. So we want to look at upper respiratory tract infections and what that really means. And so I outlined, just so we can stay on topic, examining the upper respiratory tract and discussing pathologies that we often see. Sometimes it's viral, sometimes it's bacteria, but we're going to concentrate more on virus because we're looking at the common cold and treatment modalities and supportive care measures that we use.
Okay.
So just to kind of as a disclaimer, I know that we're in a global pandemic right now, and COVID is on everybody's mind. But like you said, I wanted us to step to the side and talk about the common cold, which we see more often and has been going on. I mean, we've been seeing continuously through the pandemic. So and a lot of times people are coming in because they don't know what the common cold looks like versus what COVID looks like. So just and not saying that this lecture or this talk is going to put a definite on that, because some of it is kind of overlapping and cloudy, but just to give us some information to kind of take home and look up on our own and learn about. Okay, so upper respiratory tract illnesses is the most common site for infections for adults and for children. Children get about 6 to 8 colds per year. And in the daycares, it's even more than that. They probably get about 12 every month. Adults get about 2 to 3. And this is considered average. Now, mind you, average is average. Average is not normal, but this is considered average. It is a large economic burden on our society. We spend about $22 billion in over-the-counter medications and going to doctor's offices on upper respiratory tract illnesses. We miss about 20 million days of school and work annually, and about 10 million appointments per year are made because of upper respiratory tract illnesses. So it's a major topic that we kind of really don't think about, but if we really pull it apart, it's something that affects us on a regular basis. So the upper respiratory tract, when we talk about that, we are referring to the nose, the pharynx, sinuses, and the larynx. And I also put in here the eustachian tubes because ear infections are quite common in children. And so what happens in infection and illnesses is that this area gets inflamed. There's vasodilation, there's vascular permeability, you get nasal obstruction, and you get all this mucus kind of clogging up those areas. That stimulates the cholinergic system. We get more mucus and we get sneezing to clear this mucus out. So when we get mucus in the nose, we call it rhinitis because rhino is nose. When we get mucus in the pharynx, it's pharyngitis. Sinus is sinusitis. So all of these are just indicators of where the mucus is. Again, I'm trying to simplify it because a lot of times these names and these words, people think that these are illnesses that just kind of came and floated and came down on them. No, it's all connected. It's all mucus. It just tells us where the mucus and inflammation is within the upper respiratory tract. And so on our level, what the patient suffers is cough, congestion, runny nose, fever, facial pressure, sneezing, myalgias. These are the things that you feel when your immune system is responding and creating this mucus in your upper airway.
And to the point you're making, Dr. Palmer, the mucus equals inflammation, and that word itis refers to inflammation. Could it be due to inflammation of an infectious cause or non-infectious cause? And as you and I have had a number of conversations regarding this, it's really our own immune system that's causing this mucus production, because it's one of the earlier barriers of, the infection, as I'm sure you're going to go through that. But I just want to connect that word itis that you pointed out with mucus as you're outlining.
Yes. And so, as I said before, we have bacteria and we have viruses that get in this upper airway and create this mucus that we're talking about and this inflammation in the airway. So I'm not going to go through all of them, but we are most often in the bacterial world, we see group A strep, that is strep throat or scarlet fever. And that's pretty common. It's about 15% of the pharyngitis that we see. Viruses are the other percentage, and those are adenoviruses, rhinoviruses, coronavirus, Coxsackie viruses, and the list goes on. This is a short list, again, in the interest of time, but these are the viruses listed. Bacteria or viral, like I said, we treat them differently. For bacteria, we oftentimes use antibiotics, not in every case, but most of the time antibiotics are used. In viruses, we are not to use antibiotics. So that's colds, flus, sore throat. There are viral sore throat. It's not always strep throat. A lot of times when parents come, the child has a sore throat, they are just convinced it is strep. It is not always strep. We actually do test, and if the test comes back positive, we treat. If it's negative, we send the culture, and then we treat or don't treat based on that. And then in some instances, you have bronchitis, which can be viral or bacterial. Ear infections can be either or, and sinus infections can be either or. And this is where your doctor, your PCP, comes in handy, because they are to make a clinical diagnosis based on how you're presenting and looking at the whole picture to decide if you need antibiotics or if you don't need antibiotics. Because what is happening is, we all know, is that we're overusing our antibiotics, which creates a whole different set of health issues for us. And just a brief reminder about our viruses in the virus world versus bacteria. Viruses are not living organisms. So what I mean by that is they do not live outside of the host or outside of the body, but so long. They are dormant, so they'll be alive, but they will not be active outside of the body. So they need the host cell in order to grow and reproduce themselves. So basically they hijack the host cell and use their mechanisms in order to reproduce themselves. And most of the time viruses are systemic. So when you get a viral infection in the upper airway, depending on which virus it is, it can cause muscle pain, it can cause headaches, it can cause all of these systemic type of symptoms. Versus bacteria don't usually function like that. Where they infect is usually where you feel their effect. Looking again at viruses. So rhinovirus is the most popular, or most common, I should say, not popular, most common, and we'll spend most
Depends on your perspective.
We'll spend most time talking about that, but 30 to 50% of adults and up to 80% of children, rhinovirus is year-round. It does have peaks, but it is around year-round. We know right now we are in flu season, so flu virus is 5 to 15%, and then we have coronavirus, 5 to 15%. This is our common coronavirus. Like I said, we're not talking about SARS-CoV, we're not talking about COVID-19. This is our common coronaviruses.
You mean COVID has some family members?
Yeah, COVID has a lot of family.
They must be pretty jealous. It's getting all the press.
And then on the symptom side, all of these viruses in the upper airway responds to everything pretty much the same way. Its defense is runny nose, cough, congestion, sore throat. That is the defense of the body to get rid of these viruses. It's just the degree of symptoms progresses as these viruses become more virulent, I would say. So at the top, you have rhinovirus, which is kind of asymptomatic, mild to moderate. And then at the bottom, we have MERS, which gets into pneumonias, acute respiratory symptoms, multi-system organ failure. So it progresses depending on the different viruses. And so you mentioned the family. So we're going to look at the family. So rhinovirus is actually a part of a family called Picornaviridae, along with enteroviruses. So if we come over to this side and we look at the Picornaviridae family, we see that that breaks down into enteroviruses, and inside that we have the rhinovirus family. Then inside the rhinovirus family, they have actually done the phylogenetic tree of rhinovirus to kind of show you how rhinoviruses have the lineage of rhinovirus, like a family tree of the rhinoviruses, to see what they actually look like. And this is over, I think, 4 years it said it took them to put this together. And I know it doesn't look, I mean, this is intense. So this is showing us how many different times that rhinovirus has changed and evolved and grown and done different things. And so this is just one of our many viruses. So I did that to show, I'm showing this so that people can kind of see how changing and how quickly evolving viruses are. It's not one virus, one illness. And this is why for rhinovirus in particular, there is not a treatment for the common cold yet. And I remember in medical school, they said whoever comes up with that will be, a billionaire. But I don't think anybody's come up with that treatment yet.
You mean there's not a vaccine for each one of these?
No.
Booster, maybe.
So the common cold, upper URIs, as I've said so many times, are viral. They last about 10 to 14 days. Clinically diagnosed, so you don't need a test necessarily for these common viruses. And it's also a diagnosis of exclusion, making sure you don't have any underlying bacterial infection or some chronic respiratory illness. Risk, highest risk is among children because they're in close contact to each other. Smokers and secondhand smokers, also those people with chronic respiratory illnesses like allergies and asthma, immunocompromised, of course, and anybody in persons with anatomic abnormalities or anomalies. The environmental risk include being in closed spaces where droplets are being sprayed, or people are laughing, or concerts and things like that. Closed, crowded areas, fall and winter months, and also decreased humidity. So it's found that URIs like being indoors with the heat, just like we like being indoors with the heat.
You mentioned we don't test for these. Why don't we test for these? I mean, there's again, I don't want to get too much into the current pandemic, but there is a lot of emphasis on testing. And so these URIs are like any other URI. Is from a clinical standpoint, and anybody can answer this, but I'm just, Dr. Palmer, is there any advantage of testing for these?
So now they do have tests for some of these. And we don't do it in the clinics. They do it in the hospital. It's called a winter panel.
Okay.
And the winter panel has a lot of these viruses on it. And I think it is a feel good. It helps the families to feel good because at the end of the day, we're not going to treat. So I think that's why, over the years, we haven't tested them because the treatment is the same. So, but in this case now, I think we're using it more because we know it's not coronavirus. And I think the parents are really nervous. If it's not corona, then what else could it be? And there's so many other things it could be. And then when they get a name to it, it is soothing or comforting, and then they can kind of go home and do the therapies. But from a medical standpoint, from our standpoint, it doesn't change how we're going to treat them.
Okay. The treatment is the same for any URI, regardless of the etiology.
Right.
The current pandemic versus any other, pretty much you're going to treat symptoms, support the individual, etc.
Right.
I mean, with an active infection, I mean.
Right.
Okay.
And I think it's also for institutions, cost versus benefit of testing, of course. And then with viruses, what we've been hearing a lot of is that, they live on these surfaces for periods of time. And a lot of people are, concerned about that. Viruses will stay on hard surfaces longer than they will on soft surfaces, but the amount of time depends on the environment and the humidity and how much viral load is landed on the surface. But they do not endlessly and indefinitely live outside of the body because they need a host. They're like parasites. So they cannot survive endlessly outside of the body. For the most part, when we're talking about upper URIs and viral URIs, they are benign, but they can progress to pneumonias, meningitis, sepsis, and bronchitis. And this is when this happens, I explain to parents, when that mucus that's kind of sitting in those cavities are not moved. So that's part of our job, and we'll talk about this later. And I say our job as a society is to keep that mucus moving and do what we can to thin it out, dry it up, and get rid of that mucus. Because when that mucus sits and settles behind in the eustachian tubes, that is what we call ear infection. When it settles in the sinuses, that's the sinusitis. And so that's how, and when it settles in the lungs, that's the pneumonia. So that's how these things start off as a cold and end up being something that is more serious. So our body has its defenses, and we want to keep our body working like it should. So in a normal upper respiratory tract, we have hair lining in the nose that we can actually see. We have mucus linings, which catch those particulates. The angle of the pharynx and the nose prevent those particulates from dropping down into the airway. We have ciliated cells, which also help to move those particulates out of the lower airway and back up into the pharynx. Once it gets back up into the pharynx, we can spit it out, cough it out, sneeze it out. And also the adenoids and tonsils have immunologic cells that help to attack these pathogens. That's why it's such a it's unfortunate that a lot of people have gotten, and some of them are still getting their adenoids and tonsils removed. But that's a topic for another day.
Wait, but I know you're going to cover it another day, but briefly help us with that. I mean, in most cases, it's not a good thing to have those things removed.
Because it's part of our you're removing part of your defense system. So, I mean, the thing is, children come in with strep throat repeatedly, and that's what we need to talk about: your full immune system, not just your tonsils and your adenoids, because that means your full immune system probably needs some tweaking. Mm-hmm. But they'll take out the tonsils and adenoids. Now, some people do a lot better. Some children still get strep throat with the tonsils and adenoids removed. So, but now we've removed that layer of protection from your body. Now, our body compensates, obviously. We have lymph tissue everywhere, and the body does compensate. But it's just some children that I've seen have the tonsil. A lot of times once they do the tonsils, they just remove the adenoids at the same time. And that's the part that is a little bit troublesome for me, because if they didn't need both removed, then why are we doing that?
I mean, somebody with frequent tonsillitis or adenoiditis, I mean, I guess one should look systemically, right? I mean, why are you getting?
Well, I mean, I know it works because I've actually talked to a couple of my patients about, okay, do this for me. One of my patients said, I don't understand what's happening. In the last year, my children keep coming in with strep, and this wasn't happening before. They were from another country and they were coming into this country. This didn't happen at home. And now that we're here, this is happening. What's going on? And so I explained to her, you've probably changed the way that you interact with the environment, the way that you're eating, because there's certain things that you probably don't do here that you were doing before. And, she and I talked about it. And so she changed. She said she would change. She changed it. And then I didn't see her for like another year. And then she came back and she said, yeah, you didn't see me for a year because they weren't sick. It's like, okay, that was the goal. So, it works, but you have to be on a plan, and you have to be motivated and really motivate the children, because her children were probably 8 and 10. So they were of an age where they know what they like and what they don't like. but you have to get everybody motivated and on board because it'll help decrease your doctor visits. And you're coming into the clinic with the same thing over and over again.
Fascinating.
All right. And then on a cellular level, let's look at what happened. Now, this is actually just one method. There are different ways that the viruses get into the cells, but this is just one method. And so this is a cell in can you see my pointer?
Yep.
Okay, this is the virus, and this is inside of a capsid. So it binds to the plasma membrane. The plasma membrane pulls it inside. We call that endocytosis. Once it gets inside, it takes its coat off, gets comfortable.
Makes itself at home.
And basically it takes over, it hijacks the cell. So now the cell is no longer making and doing the function that it normally does. It hijacks it and makes it help it reproduce itself. So it releases the RNA, it translates, it replicates. The cell is doing nothing for itself. It reassembles. The viruses release outside of the cell after they get reassembled. Sometimes when they release, they kill the cell as they leave, and sometimes they leave the cell alive. So as this is happening, this, of course, eventually sparks our immune system because the body says, hold on, something is wrong because healthy cells are dying and they're not supposed to be dying. So our immune system is sparked. And so that is our innate and our adaptive immunity kick in then. But you get interferons coming into play, pro-inflammatory cells like our cytokines, which we talked about before, our chemokines and our antimicrobial peptides come in to kind of slow this process down because now the body has the responsibility of getting rid of virus, but not harming itself. So that's the balance that our body has to deal with because these viruses are inside of normal healthy cells and making them sick. So while all of this is going on, there's a loss of cellular junction. So that's why you get all of this leakage, vascular leakage, edema, mucus is being produced. As I said before, you're getting programmed cell death, but you're also getting unprogrammed cell death, cells that are not supposed to be dying are dying. And then you get sloughing of the epithelial cells. And so all of this is happening. And so this is what's happening inside of us. On the outside, all we know is that we're getting runny nose, congestion, cough, and sore throat. But the reason we get that is because our immune system is working. And I want people not to be afraid of this because this is what it's supposed to do. Now, I know that the symptoms are frustrating. I know it is annoying, but this is what the body is doing to protect itself so that this virus does not create permanent damage to your body.
And fever can also kick in at this stage also as well, right?
Yeah. And the reason I'm kind of, that's with the cytokines and the chemokines. The reason I'm not really going into fever because I'm doing upper respiratory rhinovirus, which typically doesn't lead to fever. But of course, fever comes in with influenza, para-influenza, corona, those type of viruses. So what do we do? Typically people like to use decongestants and antihistamines, which limit these symptoms. Did you want to take a commercial break, Dr. Montgomery?
Let's see, how much more you have to go?
Maybe like 7 more slides.
Oh, we can go through all the slides. We'll take a break and we'll come back and cover questions.
Okay. So typically, and I put CC up here for common cold, just to keep our mind in that zone. We treat the symptoms more so than treat the virus, but there's little evidence that these treatments help to shorten the duration of our URIs. And actually in 2008, FDA pulled some medicines from the counter because they're doing no benefit to children under 4, and they're also increasing the harm. And actually a study showed that after this was pulled, then ED visits from injuries caused by taking these over the counter decreased by 1/2. So that's major. And I see in my own practice right now with Tylenol and Motrin or acetaminophen and ibuprofen, it's seemingly used like water. And I have the discussion all the time not to use these unless we need to. And then need to is kind of a very subjective word too. But the thing is, if it's on the over the counter, people think that it's 100% safe, and they just give it constantly, and that is scary in itself. They've modified labels now also to read that if you're less than 4, do not use it unless you've gotten the instruction or from your PCP or from your doctor or from a medical professional, because they know that these medicines do have potential harm to children under a certain age, because they haven't been tested in children under a certain age. And then in 2011, the whole industry pulled some of our cough and cold medicines for some of the ingredients that they have. Now, these drug companies are very clever. They just changed their ingredients and kept their medicines out, but a lot of them got pulled at that time.
I guess if they tweak the ingredients, they can renew their patents, huh?
Yeah. Yeah. So looking at therapies considered not effective for the common cold in children, this is for children. And antibiotics, we know, do not have any effect on the common cold. Antibiotics do not help with the common cold. Antibiotics do not help with the common cold. If I can make that a song, I would.
Let's hear it, darling. All right, let's give it a beat. All right, give it.
Antibiotics don't help with the common cold. Antibiotics don't help with the common cold. Antibiotics don't help with the common cold. I hope they got that.
Yes. And that also includes if you have purulent rhinitis. So the thick green, yellow, purple, orange, red, it doesn't matter. So that is what I wanted to get out of this slide. Now, there's some other things on here that they say are not really helpful. Diphenhydramine, prednisolone, antihistamines over the counter. They list all these things as not being effective. This is from a Cochrane study. And so these are randomized controlled trials. It shows you in the evidence how many trials or how many studies they have done. So it's not, some of them have one randomized control trial over a 5-day course. So, but it gives us some kind of idea of when they look at certain modalities, what seems to help and what doesn't make any changes. And most of them didn't really make a change when you compare them to placebo. At the bottom down here, you see vitamin C, which we talk about a lot, but it wasn't studied in children. So they didn't give us a conclusion on that one. Things that they do consider effective for common cold in children is in acetylcysteine, corticosteroids, and inhalers, and that's for the people who have asthma and allergies, those type of upper respiratory things. Honey, if you're over 1 year old, nasal washes, which we talked about, vapor rubs, and zinc. Now, also you see they put on this chart the duration and the dosing for these types of things. May be effective for chemoprophylaxis. So this is before you even get sick. We have nasal washes here. We have probiotics, which is very interesting. Vitamin C, 2 weeks to 9 months before you get sick. So this should be already in your system going. And zinc, 6 days up to 5 months. And then from 1 to 10 is up to 7 months. So this is having these items already going in the system. The kit is a combination that some doctors put together of echinacea, vitamin C, and like a bee resin. That's what that is. I had to look that up.
So basically, these things on the list would be things that, as you alluded to, you would have. So let's say the cold season, winter's coming, the cold season coming, maybe November, perhaps even October. You started to take these things on an increased basis, on a regular basis throughout the winter.
Yes.
To help prophylax. Is that the
be taking them all the time anyway. I mean, it's kind of like you're prepping for the winter in the summer. So if any of us are gardeners or farmers, or you know that you prep for the winter crops during the summer. So go ahead.
Now the vitamin D, I imagine you're going to get to that, but that's one that's also important in terms of boosting the immune system.
We'll get
Gotcha. Okay.
Yeah. These are the things that they studied that was in the study.
Gotcha.
I'm just sticking with that.
Gotcha.
What was in the study? Because I know you like evidence-based medicine.
Well, I mean, a lot of different sources of evidence, but I agree. You're right. There's a lot of good sources, but yeah.
Yeah, but and then the statement I have down here at the bottom. If anything, if these modalities decrease the use of decongestants, antipyretics, mucolytics, and antibiotic use in children, and it decreases school absences. So by itself is a success story for me. I think that's a wonderful thing.
Keep it from school. And that whole evidence-based medicine phrase is all in my ears, so almost like a cuss phrase, because a lot of my colleagues use that, and then the evidence they're using is only skewed evidence that's supported by big pharma. I'm not going to get into that, but go ahead.
Yeah. All right, so now we're going to look into the adult world. Adults. Our song, Dr. Atkins. Antibiotics do not work for the common cold. Antibiotics do not work for the common cold in adults either. And then you have antihistamines used by themselves. So they're talking about antihistamines as a monotherapy. Codeine, which used to be pretty popular back in the day. They actually named nasal irrigation and vitamin C, but this is being named because it's being used when you actually have the cold. They later on say it's better used as a prophylaxis. Things that may be helpful is decongestants with or without the antihistamine, so using them together. Atrovent, which is an anticholinergic, which helps to dry up, and that's not something that we necessarily prescribe a lot of. Rhinovirus, which it dries mucus, is what it does, because it's an anticholinergic. We have guaifenesin and dextromethorphan. Also, these are all kind of drying agents, but the evidence on that says that sometimes it's helpful and sometimes it's not. And then our NSAIDs, which the acetaminophen and the ibuprofen, help with pain relief. It also, I saw that it decreases sneezing, and I didn't even want to put up here that it has some benefit with cough, because I feel like we overuse it, and that's not what it was intended to be used for. But I will accept that it helps with pain relief. Now, alternative medicine that may be helpful in adults is our echinacea. We have geranium extract, our zinc, and they actually said garlic needed to be taken 12 weeks prior, because that's prophylaxis. And that is raw garlic, so raw crushed garlic, because once you cook it, then you change that allicin that is the healing property in it. It changes once heat hits it.
Do you know if the fermentation, low heat fermentation, should preserve that? Should it?
I don't know if it preserves it. It seems like it's they specifically say crushed raw garlic. So I don't know if when you fermented that changes the chemical structure of that. I will have to look that up. And vitamin C. So this is where vitamin C comes in. 40 days to 28 weeks, so around 3 months before getting that vitamin C in your body. Now, the thing is, if we're eating right, you have it in there already. I mean, that's the magic of it all. If we're eating like we should be eating, then it's already going to be there. It's nothing to really worry about. But we know that can be a challenge. So other things that we can do to kind of support our immune system is, of course, rest and hydration. But there are things that we should be not doing to not add to the insult that's happening to the body. So stop all forms of smoking. That includes hookah and everything else that's out there. Stop all forms of alcohol,
What's
all
hookah?
forms of caffeine, high fatty foods, dairy, processed foods. All of these things are creating more of an issue for our immune system. So you're just making this illness last so much longer than it needs to. Of course, hand hygiene, sunlight, exercise, and guess what's next?
What's next?
Nutrition.
Well, just shoot me right now.
So we had to go there because that's what we talk about on this show.
Yes.
So there are many vitamins, but we're naming vitamin A, C, D, E, zinc, selenium, omega-3s. And of course, we know that in these foods, there are more vitamins than what man has discovered. So that's the magic of taking this into your body, is you're getting so much more than we even know exists. So it is hypothesized that these vitamins help the body to produce antibodies. It helps in the proliferation of the lymphocytes, white blood cells, and it helps reduce the stress, oxidative stress on the body. They also are starting to realize that micronutrient deficiencies and general malnutrition, which many people are micronutrient deficient and malnourished, creates an immune system dysfunction altogether. So a lot of people, even though I know that when we think about malnourishment, we think of people being cachectic and wasted and small, but there are a lot of normal weight and overweight people who are malnourished.
Amen.
Also micronutrient deficient. So we have to know that that is happening, because if you're not eating the nutrients and you're not taking them in any form, then you are going to have deficiencies. And the scary part, or the sad part about that, is that there are viruses out here like Coxsackie and influenza that really like that situation, because they get increasingly virulent and replicate even more when they have a nutritionally deficient host cell. So that gives them a nice, beautiful home to settle down in.
And I mean, to your point about the malnutrition, I mean, most people who are overweight or obese are malnourished. And to emphasize that point, I mean, they're over caloried, but
Yes,
malnourished.
exactly.
And so, and I think that's an important point that you made, because nutrients are different than calories necessarily. I mean, so calories are part of the nutrients, but they're not always just going to get a lot of calories. I mean, you're getting a lot of nutrients.
Right. And then I also, since you said that, I'll re-emphasize that in the pediatric world, a lot of people feel like a fat baby is a healthy baby, or toddler is a healthy baby, and that is not true. And I spend a lot of time trying to explain that to families. Just because the baby is full and does not mean that we're at a good position. And many times we have to do some work to get that weight off the baby before we get into, and I say baby, I'm talking about toddlers, until we get into danger zones. Okay, and so I'm just going to pull out 4 of those zinc. They're food sources of zinc. And what you see here are our lentils are here, chickpeas, sunflower seeds. I think those are Brazil nuts down there in the corner. Not my favorite, but they're here. And those are good sources of zinc for us, and also supplementation. So we know nowadays supplementation is almost, I would say, necessary, because sometimes our foods lack all of the nutrients that we need. So we use the supplements to kind of fill in where the foods may be lacking. Vitamin C. When we think of vitamin C, we oftentimes think of citrus, but vitamin C is also in our broccoli, Brussels sprouts, cabbage, bell peppers. So it's in many different foods. And I just put a longer list up here for that. So you don't think it's just oranges, because it's not. And all the supplementations with liposomal vitamin C and the Atkins often tell us about buffered vitamin C. We have omega-3s, which I know a lot of people take fish oil, but there are plant-based sources for that. We have our chia seeds, our hemp seeds, blueberries, our walnuts, And the reason that I'm not an advocate of the fish is not just because I'm plant-based vegan, but that's part of the reason. That's one. But two, the oceans are so polluted. So whether it's wild caught or fresh, the fish are in contact with the water, the oceans, and with the pollution level being so high, they are taking in those items and toxins into their cellular structure, which means when we eat that, we're taking that into our cells. So the benefit of the omega-3 that the fish has is probably negated by the toxins and the other things that could potentially be in their cellular structure from being in that environment. And then our vitamin D, we know vitamin D is a hormone actually produced by the sun, so getting outside. Unfortunately, most of us nowadays, it's almost impossible to probably get outside as much as we should with the full-time jobs. So we also do supplementation with D3 to help us get there. Okay, so I'm hoping that I shed some light on the upper respiratory tract and upper respiratory tract infections being viral. Antibiotics do not work. And also trying to come up with a medication, because I think people want a medicine to fix everything, a medicine to fix a virus or the cold, let's stick with rhinovirus, is very difficult because it's so fluid and evolving and changing so rapidly. So, this is why lifestyle modifications is where you're going to get the best bang for your buck. And it's going to be preventive, but even if you do catch it, because sometimes we are still human, we are still interacting on the planet. You may come in contact with something, you may catch something, but you should have fast recovery if your lifestyle is in such a way that it can fight off these viruses faster.
Wonderful, wonderful. Well, that's an excellent presentation. Whoa, look at that garden. Wow, impressive. I see the stone there. Oh my goodness, you're a big time gardener. That's a recent harvest?
That is last year.
Last year.
Yeah.
Still very impressive. Wonderful. So what we're going to do is take a quick break here, and we're going to come back and address some questions and answers. I made some notes, and I think you guys may have seen some. We will go a little bit over, but I think it's going to be worth it. It's a very important topic and a very great presentation. I want to make sure we cover all of these questions. So I saw a lot of great questions. So hang tight. We'll take a break. We'll be right back.